we are now going to move to some case discussions which Chiara is going to lead on. And I'd like to invite up to join us on the panel the experts who are going to... let me just call everyone up first. So I'd like to invite the following experts from around the world who are going to partake in this multidisciplinary discussion of a couple of cases to replicate what actually happens in real life when patients with cholangiocarcinoma are discussed. So I'd like to invite Chris Wadsworth, colleague at Imperial, consultant gastroenterologist and HPB physician. Ganesh Radhakrishna, clinical oncologist from Christie. Prakash Manoharan, radiology consultant, nuclear medicine physician from the Christie. I don't know.
I think he has some issues and he couldn't attend today.
He's not attending, okay. Mr. Hassan Malik, consultant, hepatobiliary surgeon, clinical lead for digestive surgery from Aintree. Brian Davidson, I know I'm sitting in your seat, Brian, but I will be leaving in a second. Professor Brian Davidson, consultant surgeon at the Royal Free, and Professor Lorenzo Rimasa, consultant professor of oncology at the Humanitas University in Milan. Right. So if you could come up and sit at your respective seats, I'll be moved to the edge. And Chiara will lead the discussion.
Thank you very much. So what we decided to do, we have heard a lot about clinical trials and novel opportunities, but we wanted to take an occasion to really go through the standard of care, and rather than having in a regular lecture setting, try to discuss the standard of care within the context of what happens in our clinical practice. So the first patient is an advanced cholangiocarcinoma patient who unfortunately was not deemed to be resectable. So these are our disclosure of the panel who is being involved into this discussion. So the patient is a fit young lady, 47 years old, with a good performance status, attended the clinic. Her presentation symptom was with ascites and some abdominal pain. She was quite fit and in absence of comorbidities. So when she presented through the A&E, she had obviously a list of investigations, including scans, which showed a predominant liver mass. This was unfortunately associated with other sites of disease in the lung, in the abdominal lymph nodes, and also some peritoneal disease. On blood tests, there was a preserved full blood count, as well as liver and kidney functions were preserved. And in terms of tumor markers, there was an increase of alpha-fetoprotein, which was at a level of 30, with a normal value that usually stays at 5. A CA 19.9 was only mildly increased to 80, and I remind you that a normal value is about 45. And then a CEA, which is an extra tumor marker we test at times, it was within normal limits. So she underwent a liver biopsy, which has shown the picture of an adenocarcinoma, small duct adenocarcinoma, CK7 positive, and it was HEPAR negative. So on the basis of these data, then the question is, we have now defined at the MDT that this was likely to be a metastatic intrahepatic cholangiocarcinoma in a young, fit lady. So what would be the oncological options? And I'm happy to ask Lorenzo Rimasa to really give us an overview of what can we consider in this case. Lorenzo, you should have your slide up. Yes.
Okay. Thank you so much, Chiara, and thank you, Shahid, and thank you, Helen and AMMF for the kind invitation. It's an honor to be here, and good morning to you all. So I'll go through the first-line treatment for patients with advanced or unresectable cholangiocarcinoma. You have already seen some slides, so I will be going faster. So this slide summarizes the timeline of drug development in biliary tract cancer, and in the red boxes, there are the treatment options that are available in clinical practice, with some differences across countries, but are available in clinical practice. As you can see, for more than 10 years, we had only chemotherapy, cisplatin and gemcitabine, and I'll show you the curve in a while. And then in 2022, the data of the TOPAZ-1 trial were presented and then published. So cisplatin, gemcitabine plus durvalumab became the new standard of care. And a year later, 2023, 2023, also the Keynote 966 trial was presented and published, so there is another option. Again, it depends on the countries, but cisplatin, gemcitabine, and pembrolizumab. This slide showed the results of the ABC02 trial, and the trial established cisplatin plus gemcitabine as the standard of care. As you can see, the combination improved survival compared to gemcitabine as a single agent. For more than 10 years, all the trials were negative, and finally, the TOPAZ-1 phase 3 trial met its primary endpoint and also the secondary endpoints. As you have already heard, this trial compared the standard of care cisplatin gemcitabine versus a cisplatin gemcitabine plus durvalumab, that is an immune checkpoint inhibitor, so immunotherapy. Chemotherapy was administered for 8 cycles, and durvalumab was continued until disease progression. And you can see that the combination of chemotherapy plus immunotherapy improved overall survival. You can see the curves on the left on the slide. And in the blue boxes, I've highlighted that the benefit of the combination was confirmed in all subgroups of patients analyzed, and especially regardless of the primary tumor site and the disease status. So the combination is active in patients with intrahepatic, extrahepatic, or gallbladder cancer, either if they have a locally advanced disease or metastatic disease. The authors tried to identify some predictive or prognostic factors because, as already mentioned, we don't have any biomarker or factor to select which are the patients who might benefit more from the treatment. But then only 2 factors, neutrophil to lymphocyte ratio, that is a kind of marker of inflammation, and the CA19-9 levels were identified as prognostic, but not predictive. So once again, all the patients might benefit from the treatment. We don't have to select patients for this treatment. There is also a benefit in progression-free survival, again confirmed in all subgroups of patients, and a benefit in response rate that is higher, as you can see in the purple box compared to the orange one. And another important point is that more patients, in the group of patients who had objective response, more patients had maintained the response at 1 year or 12 months. The safety profile, other important point, is good. There were no new safety signals. We observed the adverse events associated with chemotherapy and the adverse events associated with immunotherapy, but the combination is very well tolerated. And the quality of life data, actually the patient-reported outcome data, have been just published in the Lancet Oncology. Here the reference is not updated because it was last week. And as you can see, there is a numerically longer time to deterioration in quality of life with the addition of immunotherapy. There is no difference, actually. But what is the important point is that we added a 3rd drug to the combination, and there is no worsening in quality of life. So this is a key point together with the efficacy of the combination. And at the Cholangiocarcinoma Foundation in April this year, the 3-year overall survival data were presented. And as you can see in the curves, there is a kind of plateau of the blue curve. So there are patients who are alive at 3 years, and it seems that there are patients who maintain, have a long overall survival. And what is shown in the graph on the right-hand side is that the benefit of the combination of chemo plus immunotherapy increases over time. The blue bar are the chemo plus immuno, the orange bars are chemo alone, and you can see that the benefit is 1.15 per 174, 2.12. It's a way to show that the benefit increases over time. This is something that can be expected with immunotherapy, but this is something that was not shown before, so this is another important point from this study. And sorry for the busy slide, but on the bottom left, you can see that also there is another important point, that patients who have objective response, but also stable disease, benefit more than patients with disease progression. But the point is that if the patient has disease control, the survival is longer. So it's not needed to have a response, but also stable disease is a good point. We also published, and then there are other real-life publications. These are the first real-world data published from an Italian group. I'm part of this. And what is interesting is that we had exactly the same results in a real-world situation, in a real-world setting. So the data from a phase 3 trial are reproducible in clinical practice, and this is another important point. There is another trial that is the Keynote 966 that tested the same chemotherapy combination, cisplatin, gemcitabine, plus or minus pembrolizumab. There is a small difference in this trial. So gemcitabine was administered beyond 8 cycles. Only cisplatin was stopped after, 8 cycles, and only cisplatin was stopped at 8 cycles. The trial is positive, and once again, there is a benefit in survival, regardless of the primary tumor location and regardless of the disease status. In this trial, there is no benefit in progression-free survival and a response rate. This can be at least partly related to the continuation of treatment with gemcitabine, also in the non-immunotherapy arm. It can be related to the characteristic of the study design. But what is important is that the duration of response is much longer with immunotherapy compared to chemotherapy alone. So again, this is a positive trial, and this is another option where in countries where pembrolizumab is approved and reimbursed. The safety profile is good, and the quality of life is good. So as in the TOPAZ 1, there is no worsening in quality of life adding immunotherapy to chemotherapy. So this is a confirmation that chemo plus immunotherapy is better than chemotherapy alone. And these are the updated results presented last year. There is one more trial, just one slide. This is interesting because this trial tested 2 different combinations. Again, cisplatin, gemcitabine, plus atezolizumab, that is another immune checkpoint inhibitor. And in the other arm, they added a 4th drug that is bevacizumab, that is an anti-angiogenic drug. This is a phase 2, so it is not supposed to change the clinical practice. But what is interesting is on the right part of the slide. So the investigators tried to identify some biomarkers to select patients who might benefit more. This is something that we need in clinical practice. Unfortunately, they identified some markers, but they are markers predictive of bevacizumab and efficacy and not of immunotherapy. So it's interesting from a scientific point of view, from a research point of view, but not something that we can use in clinical practice. So still, chemoimmunotherapy is for all the patients who don't have a contraindication to the treatment. This is more for second line, but it's important to mention also in first line that up to 45% of the patients, we have discussed a lot about this, may have potentially actionable alterations. So the molecular profiling should be done as soon as possible, depending on the countries. But for instance, in the ESMO guidelines, is mentioned before first-line treatment or during first-line treatment. The key point is that we don't have to wait after the first line to ask for and to do the molecular profile. We need to have this as earlier as possible. And in the British Society guidelines, indeed, in recommendation 39, it's mentioned the treatment, so chemotherapy, cisplatin, gemcitabine, and immunotherapy. And the recommendation 41 in the bottom left of the slide is that the molecular profiling should be done at the earliest opportunity, and this is important as well, results and treatment options should be reviewed by clinicians with appropriate expertise. We have heard that sometimes clinicians do not have the appropriate expertise in this disease. And for patients who have contraindications, comorbidities, or for some reasons cannot receive a triple combination, chemotherapy alone with a gemcitabine or sometimes oxaliplatin instead of cisplatin can be an option. And there is now an ongoing trial testing also gemcitabine plus durvalumab, for instance, to avoid the administration of cisplatin. So to conclude, for first line, the standard of care is represented by chemotherapy, cisplatin, gemcitabine, plus immunotherapy, either durvalumab or pembrolizumab. If there are contraindications to immunotherapy, chemotherapy alone, combinations or monotherapy depending on comorbidities or other potential contraindications. There are ongoing trials in first line. You have already heard about some of them. And these trials are testing new immunotherapy or targeted agents in first line. And the last point is the key point. The molecular profiling should be done at the earliest stage as possible because it is key in the therapeutic pathway. And this was my last slide, I think.
Thank you, Lorenza. So the patient did not have any contraindication and she was fit, as we have seen before. So she was initiated on a first-line systemic anti-cancer treatment with the cisplatin, gemcitabine, and durvalumab. She had a very good tolerance, and the first restaging at 3 months showed that there was a partial response with a tumor shrinkage of more than 30%. Then we continued. As you know, that the TOPAZ trial includes 8 cycles, so 6 months of treatment. And before we continue, meanwhile, we had submitted the histological, the genomic profiling, as Lorenza has recommended. And the patient was found to have a IDH1 mutations in the 132 codon in the tissue. And then as part of research, this was also confirmed in the ctDNA analysis. So she was continuing on the same program. At this moment, we did not change our plan according to the molecular profiling. And what we could observe is that at 6 months, she actually had a further response and a further shrinkage of her tumor. So the question here is now, according to the TOPAZ trial, we should stop with the chemotherapy and continue with the maintenance durvalumab in immunotherapy. But I think that I wanted to just add one extra question. What should we do in presence of a benefit and good fitness, especially in these cases where patients respond, very well? So we have a couple of scenarios to consider if we want to expand even beyond this case. In one case is if we have a non-metastatic cholangiocarcinoma. So let's hypothesize that this patient had only that dominant liver lesion and she did not have any metastatic sites. So is there in that case any role for radiotherapy? And is this something that we should start to consider? So Ganesh, I was really hoping to get your opinion on this.
Thanks for that. Radiotherapy in biliary cancer, what I'll do is I'll just do a rough outline of where we're at the moment and hopefully give an answer, hopefully. Radiotherapy is, it's not complicated. We need to get a dose of radiation to the tumor, and that's represented on this graph with the black line on the left. So you want to get as high a dose to get as much tumor control as possible. But radiation is delivered with multiple beams, and radiation can therefore be delivered to certain structures and organs. And when you're talking about biliary tract cancers, this is primarily the liver itself as well as the bowel. And if we want to get our tumor control and unfortunately, the dose that we need to get tumor control is also the dose that may cause significant complications, then we have a problem in terms of offsetting the delivery. So what we want to try and do is keep those two curves as far apart as possible. And what we are trying to do is use imaging to identify the tumor as precisely as possible to deliver that dose, but also try and identify where those particular organs are and try and reduce those structures. And so we're delivering a high dose of target volume. And with image-guided radiation, we can actually now personalize that treatment. I can go on and wax lyrical about this for about an hour, but I'm not allowed to. So you'll have to take my word for it that essentially we can, with high-quality imaging, be very precise in our definition of radiation therapy. And Prakash isn't here, but we tend to, as a standard for HPV cancers, use both a clinical radiologist and an oncologist together to optimize these treatment plans. We can be adaptive. We can change the treatment and adjust it for whilst the patient's on treatment. So all linear accelerators in the UK should have something called a cone beam CT. So you get a CT image or a three-dimensional image, and we can adapt the treatment accordingly to avoid structures. But we need to also account for the fact that these treatments are delivered usually over 2 to 3 minutes, and patients will be breathing and the bowel will be moving that time. So we have to take that into consideration. So our fundamental objective is really to deliver a high dose to that target volume. We have a number of ways of doing that, and the most promising way at the moment, certainly for primary liver cancers, is to use stereotactic ablative body radiotherapy. So these are big doses of radiation equivalent to what one might receive over a course of maybe 5 weeks in 5 treatments. And then there's the adaptation. As I said, we can change and adjust that patient position to cover the tumor or avoid a structure, but we also now have real-time adaptive radiotherapy where we can actually plan the radiation whilst the patient's on the couch to try and deliver that treatment as precisely as possible. So what is the critical issue with primary liver cancers? Well, the thing historically that we have been concerned about is because we didn't have the level of precision that we did before, we would have this complication called radiation-induced liver damage. And classically, the classical RILD is when we used to use whole liver radiation, and that would cause potentially fatal RILD. We're now seeing non-classical RILD where you have a transient transaminitis and potentially up to a 2-point increase in the child's Pew score. So that's an assessment of the baseline liver function. But with optimized treatment and our understanding of that, we do take that into account in our radiation planning. But what is crucial with cholangiocarcinoma is clearly we're irradiating the biliary tree. And this has resulted in what we're now recognizing as central hepatobiliary toxicity, where there's possibly an increased element of biliary stricturing, whether that's due to inflammation or reaction to the tumor or the scarring as a consequence of radiation. I think it's difficult to fully be confident about. It's probably a combination of all of those things. And what we do know is that certainly radiotherapy has an effect in biliary tract cancers. As already highlighted by Professor Thornburn earlier, we do use chemoradiation, the Mayo regime, in patients who may have had an option for surgery. Chemoradiation of the Mayo regime included chemoradiation followed by what was called a brachytherapy boost. Brachytherapy is the insertion of a radioactive source to deliver radiation intraluminally. So it is invasive, and it has some problems in that it can sometimes be very difficult. And in fact, if we look at the series with brachytherapy, up to 25 to potentially 30% of those patients were not able to have their brachytherapy because we couldn't cannulate the biliary duct. And so you're losing that radiation effect. And that is fundamentally why we have opted for proton beam therapy. Proton beam therapy spares a substantial amount of the background liver and the background tissue, and so we can treat larger volumes to a very high dose. And dose matters. So this is a very interesting study looking at the effect of that dose to the tumor. And there is a clear survival advantage based on this series when you are able to deliver a very high dose of radiation. And within this, the patients had a combination of long-course chemoradiation, so over 5 weeks, SABR, but they also had patients who had proton beam therapy. So they were able to optimize the dose and deliver that high dose. And you can see here in all the disease-free survival, overall survival, progression-free survival elements, if you have a higher dose, which is represented in that blue line, there is an advantage. So what about stereotactic ablative body radiotherapy? Well, this is also called stereotactic body radiotherapy. There haven't been any formal studies up until recently. A meta-analysis of 231 patients suggested that it probably was feasible and there was an advantage in addition to other treatments. But as the learning curve will demonstrate, we we have to be conscious of the fact that we will see more problems with biliary obstruction, potentially cholangitis. ABC07, which my colleague Maria at UCL as the CI is going to be presented, I think it's this week. So the results, unfortunately, are embargoed. But it does, I think, safe to say, certainly within the UK, demonstrate that we are in the UK in a position to deliver safe, high-precision radiation therapy for primary cholangiocarcinoma, if indicated. But it does also allow us another treatment option within the armory. So very quickly on this, is we have a number of different platforms that we can deliver radiation therapy on, and that allows us to improve our precision. And what I mean by precision is not just the target, it is also enabling us to identify how we might improve the outcomes further for patients, particularly on the improved systemic therapy baseline. So patients who now is clearly being shown to improve the outcomes with immunotherapy and may perhaps have oligorecurrence or oligoprogressive or even local progression whilst they're on the immunotherapy, rather than saying, well, unfortunately that's it, we have to change the therapy. We might be able to add in SABR into that paradigm. These are short fractionation schedules to try and perhaps maintain the patient on the treatment and continue. So these are subject to trials. We also have MR guidance, so that image that is moving around is showing you what happens during a course of radiation therapy to the abdomen. And as you can see, the heart's beating, the patient's breathing, the patient has an abdocompression belt, so that's why the diaphragm isn't moving so much, but the liver still moves, deforms. We can account for all of that whilst the patient's on the couch. But the critical bit, which is that white bit that's moving back up and down at the side of the liver, that's the pylorus and the duodenum. These are critical structures. If we put too much dose into that area, we can cause perforation and bleeding. So once again, with MR-guided adaptive radiotherapy, we can account for that motion and account for the dose that's delivered whilst the patient's on the couch. It is obviously a longer treatment, and we need to work out whether it's beneficial. So that's improvement in image guidance. And on the left, we have proton beam therapy. And what you can see there, to cut a long story short, is that you can see that area in green, which represents the area that we're targeting with the proton beam. And with proton beam, because it can stop, it spares a whole amount of the background liver. And so we are able, when we're comparing it with modern image-guided radiation therapy, deliver a much higher dose of radiation while still sparing the background liver and the background structures. So I think in conclusion, it may provide a benefit. We probably are more confident in the non-metastatic setting, and I guess in this patient, it's a good question, but we haven't got the evidence to support that. But we also need to take into account that these treatments do come with a whole new gamut of complications, and it really needs a fair bit of expertise to monitor the patients and recognize the problems and improve the imaging guidance of the radiation therapy. So, as I said, firstly, radiation is not very complicated. It's all about the dose. If we can get the dose in, we can probably achieve a good outcome, and that's probably why we need to discuss these patients more at the MDT. And yeah, we'll wait for ABC07, hopefully allow us to integrate more SABR into the paradigm. Thank you.
Thank you, Ganesh. So while we are waiting for the data of the ABC07, we hope this can change what we are going to do. In these specific patients, unfortunately, radiotherapy could not be considered because there were metastatic disease, some other sites. So I wanted to bring another area for discussion, however, as we know that we should now, according to the TOPAZ trial, interrupt the chemotherapy. So in a patient like this, where we can see that there is a progressive response and the tumor seems to respond better at 6 months rather than 3 months, would any of the oncologists in the room continue chemotherapy in association with durvalumab? Lorenzo, John, do you Do you have any thoughts?
I understand the question. Probably we will, actually, for sure, we will be discussing this at the multidisciplinary team meeting to have also the opinion of other colleagues. But in general, we'd stop after 8 cycles. Also because there is the problem of the toxicity. The treatment here is well tolerated, but in general, I prefer to stop after 8 cycles. We have the evidence based on the ABC02.
John, any patients where you might continue at all?
It's very patient dependent. Some patients say, look, it's working. Don't stop it.
And the fact that this patient has an IDH1 mutation and some preliminary data might suggest a better response to platinum, would that make any difference in your decision?
No, I don't really believe those data. Yeah.
So we had agreed we didn't continue chemotherapy beyond these months, beyond the 6 months, and so the patient was maintained on durvalumab. So the maintenance regimen is 1 administration every 4 weeks. And as you can see, the radiological response, which is highlighted by the purple bars, was maintained, and the tumor marker, the EFP specifically, continued to drop down until about 13 months, when we actually had to stop the treatment because of tolerance. And we could see that the tumor started to grow back. In reality, from the tumor marker, you see that there has been a slight increase, but he had not really made a big jump. But on the CT scan, there was progressive disease, and in this case, it was also associated with symptomatic progression. So now we have a patient who has had a very long response to cisplatin, gemcitabine, and durvalumab. We have a time to progression of almost 19 months. We know from the genomic profiling that this patient is IDH1 mutated. So, John, what would you think it might be an option for second line?
Thank you. So these are the standard options for second line, which we heard about a bit already. On the left is FOLFOX, which is still the international standard of care, and pretty much anywhere else on the planet, this is the only thing that you would be offered. There is another alternative, which I sometimes offer to patients, and that's a drug called regorafenib. So we've heard about targeted treatments where the drug is targeted to a specific genomic abnormality, FGFR, IDH1, all the others that we've heard about. Regorafenib doesn't really do that. Regorafenib is what's known as a much dirtier kinase inhibitor, so it inhibits a little bit of all of these alterations. And there was a trial which demonstrated that it was effective, at least in part. And these two treatments will never be compared to each other, because I don't think anybody has is planning to do so. But regorafenib may offer an option for patients who really can't face the idea of more chemotherapy. After all, it's a tablet, and the side effects are somewhat better. So in some people, that could be considered an option, and you can get this off the drug company currently without any difficulty. Those are the standard options if you don't have any one of those genomic abnormalities about which we've spoken for the best part of a day now. IDH1, so just to go back to just a little bit of blurb on IDH1. Just go back to the tumor agnostic question we had earlier. This is a tumor agnostic genetic driver, so it's responsible for cancers in a number of different situations. Intrahepatic cholangiocarcinoma is one of the lead ones, but it's also present in a number of other things. Gliomas, chondrosarcomas are cancers of cartilage. T-cell lymphoma, SNUC is a very strange cancer of the nasal cavity, and AML is leukemia. And so it is a agnostic genetic driver across these different cancers. So arguably the drugs that we use for one could work on the other, and there's quite a lot of evidence to support that. How often does it occur in cholangiocarcinoma? Well, probably something, well, these particular data said, which came from, I think, Memorial Sloan Kettering, said about 13%. It's probably somewhere between that up to about 20%. And really only in the intrahepatic cancers. Its partner in crime, IDH2, actually works in exactly the same way, causes the same abnormalities in exactly the same way, but it's a slightly different enzyme. The enzyme is located in the mitochondrion. IDH1 is located in the cytoplasm. It's just different place, but as far as we're concerned, potentially different drugs, but it is less common and even more neglected than IDH1, I would argue. And this is the way it works. It leads to something called hypermethylation. So methylation is when your DNA is covered with bits of nucleic acid, bits of RNA, and this changes the way in which your cell behaves, and this is the way in which the cancer is generated, because it changes the way in which your cells behave and the cancer grows. And this is demonstrated in many ways, and primarily in the leukemia setting. And this was the big study which we did about 4 or 5 years ago now, called the Clarity study, where patients were randomized. So you were found to have this IDH1 abnormality, and half of you got placebo, so nothing, chalk, and half of people got ivosidenib. And this was a crossover study, so people who did badly on the placebo were then eligible to receive the ivosidenib, and approaching 70-75% of people who had the placebo to begin with did exactly that. But it could be seen that if you had the ivosidenib first, so that's the blue line, you stayed free of disease, so your cancer did not, or free of progression, your cancer did not get worse as quickly as it did if you had nothing. So on the basis of this. And the reason, you can see that for some people it doesn't work very well at all. So about half the people, getting on 40% of people, really it has no impact whatsoever. But for a significant number of people, up to about 20-30%, there is long-term stabilization of the disease. That's the blue line. So really this is an extremely, can be an extremely helpful drug in some people. The question, of course, as with the immunotherapy I was talking about earlier, is who benefits, who's on that sharp decline at the beginning and won't really benefit from the drug. And perhaps that's available through further studies. So this is the way in which, these are some data suggesting the way in which people are resistant to this drug. And so we can slowly tease out who's going to benefit and who's going to not benefit, and save those people taking it for no reason. So, in conclusion, you should. There's FOLFOX as per ABC 6, but if you have a targeted or an actionable alteration, definitely these are the better options. Thank you.
Okay, thank you, John. So this patient was started on ivosidenib, and she initially had at least biochemically a good response, and she's still on treatment at the moment. So we are following her up, and she's continuing with this treatment. So it was a clear example of how patients can follow up on targeting therapies if we can achieve genomic profiling on time. So in conclusion, we can say that the recommendation for first line is cisplatin and gemcitabine plus in immunotherapy, and in UK we do have access to durvalumab, so that is something that can be considered and should be considered nowadays in all patients. Genomic profiling should be initiated at the beginning of first-line SACT, and then if no metastatic disease, radiotherapy is something that should be considered and probably the case brought back to discussion at MDT. If not, and if the patient is metastatic, then a second-line option should prioritize targeted therapies if there is a druggable molecular alteration. I mean, we are open to discussion from the public here, the audience here, or online. And meanwhile, while we're waiting, if some questions arise, I want you to ask a couple of questions. Lorenza first. We haven't really expanded very much in terms of contraindications for immunotherapy. So I know that it's still kind of a gray area. So what do you consider in your practice a clear contraindication?
Yeah, this is another important point. I consider absolute contraindications only severe autoimmune disorders like lupus, for instance, not the classical autoimmune disorders like thyroid disorders. Hypothyroidism is not a contraindication. And at least so far, prior organ transplant for this reason or for another reason, because we know that immunotherapy can increase the risk of rejection. Maybe the data are not so bad as we thought in the past, but at least so far it is a contraindication. And I think these two are the only absolute contraindications. Then you have, of course, to consider other diseases, comorbidities, concomitant medications, but I don't think there are other absolute contraindications.
So a patient with an ulcerative colitis that is severely and actively, you have given immunotherapy?
It depends. It's not, if severe, I don't give immunotherapy. So it depends on the patient. On grading of the different things. And do you involve the gastroenterologist in this discussion? Of course. As I said, we always discuss the multidisciplinarity in meetings, and if there are patients, for instance, with ulcerative colitis, Crohn, or other diseases, we involve the gastroenterologist.
So, I mean, Shahid, do you want to comment on?
Well, no, I was just going to say that we have some questions.
Yeah, good.
That we have some questions come through. Is now a good time to
Yes,
bring
please,
them
go ahead.
Okay, so we've got some questions come through about this case, which I'll just put to the panel. First question is a patient question. Are there any plans to explore histotripsy more in the UK, as it seems to have had a lot of success in other countries? For those of you who've not heard of histotripsy, it's a non-invasive procedure where you use high-intensity sound waves to selectively destroy cancer tissue in the liver. Histotripsy, are we going to look at that in the UK? Any?
There's no plans to look at this. It comes into the category of locally ablative treatments, of which SBRT is probably the most well investigated. We would always welcome a clinical study looking at any further ablative therapies. So far, it's, I don't know of any.
Okay, Brian first, then Hassan.
I could maybe comment on that because I've been doing work on histotripsy for more than a decade. The change that's happened in the last 6 months is that there is a new system which has far better parameters. It's got image guidance combined with the histotripsy, and it can ablate large volumes of the liver as a day case procedure relatively painlessly. So it's a technology development and it requires evaluation, but it's very interesting.
Okay. Hassan, did you want to add something?
Not necessarily for the ultrasonic thing, but the other thing which has been mentioned is a very old thing, which is hepatic infusional chemotherapy, which hasn't really gained favour in the UK. Well, there's some interesting data from Holland where I think it was recently presented, where for multifocal intrahepatic cholangiocarcinoma, liver-limited disease, they've seen some really interesting results with just old-style chemotherapy. But it is an invasive procedure in someone who starts off in a palliative setting, often done surgically, can be done robotically. And I believe the interventional radiology technique is developing as well. So that may be something that comes along in in the future as another option.
Okay, thank you. And next question is, what are the panel's thoughts on timing of radiotherapy in a patient with localized yet inoperable disease? If a patient's responding to cisgem durva. So if a patient's responding, at what point would you consider interrupting durva and considering radiotherapy?
It's a very good question. I don't think we know. I think I guess I'd reframe the question as what do you want to try and achieve with the radiation therapy? So if you're getting a good response and a maintained response with the Dervla without any significant morbidity, then continue the Dervla. But if there's an indication where perhaps tolerability is a problem or we want a treatment break, then SABR is a possibility at that point. Or, and this is very controversial, is I guess the question of oligoprogression.
Yeah, I mean, I suppose there's so many permutations and combinations, and if you adopt the approach that everything has to undergo a randomized controlled trial, then it's very difficult to assess every permutation, and maybe actually we need easier ways to assess interventions.
I think if I can make a small comment, maybe we need to wait for the date of the ABC07. The design there was that after 3 months, we would, the patients have been randomized to continue with chemotherapy up to 6 months or providing radiotherapy, and so that at least will give us an answer if that may be a good strategy. I think then it becomes more complicated to understand what we do now that we have durvalumab.
Yeah. Do we have any time for more questions, or do you want to move to case 2?
I think we have just 30 seconds left, so maybe one last question.
Okay. Sorry, Brian.
Can I ask a question?
Sure.
If this patient you presented didn't have metastatic disease and there was the possibility of downstaging for resectability, would you use the same regime? And at what point would you reassess and restage the disease to assess possible resectability?
Yeah, I mean, obviously, if you do have a patient with localized disease, we bring that back in discussion at the MDT to assess resectability. In patients who are very fit and where there is an opening window for surgery, sometimes if they have a very good tolerance, I might even decide to continue with chemotherapy with cisplatin if we see really a continuing response. But I would probably say that 6 months is the time where you really give the chance to understand if the biology is a good one to operate or not. And then I'm usually guided from my colleague surgeons as well.
Okay, there's quite a few questions coming in. Can I ask one final question before we move to case 2?
Yes, I think we can.
Why is gem-cis durva not an option available once a patient was previously treated with gem-cis? Is this based on evidence or NHS policy?
So it's a question of timing. It's a question of timing. If you've had cisgem first, then you're probably going to be if your cancer progresses within a short time of finishing cisgem, then you're resistant to the cisgem. And so there's no point in giving more cisgem, even if it's with durva. So that's the one thing. The second thing is purely a data thing. There's no data to say that giving that whole combination is going to be better than something else like FOLFOX. And the third thing is that actually the form on which we have to request durvalumab specifically stops us from doing that.